Hello.
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 Hello. Hello, Namaskar.
নমস্কার, ডক্টর রশ্মি সরকার এখানে।
Yes, I'm Professor Shahidullah Sikdar, President
Hello,
of
Dr.
Bangladesh
Sikdar.
Academy. How are you, Rashmi
I am
Sarkar?
fine here. I am fine.
Very good. You are welcome.
Sure. So, how many people are supposed to be logging in?
Usually, more than 100 people are participating.
Right.
নমস্কার ম্যাডাম।
নমস্কার, নমস্কার। How are you?
কেমন আছেন?
ভালো আছি।
সাইফুল
স্যার, আসসালামু আলাইকুম স্যার।
আসসালাম। তোমার কি মোটামুটি সবাইকে তো জানাইছো, তাই না?
জি স্যার, জানানো হয়েছে। আশা করি হবে। অনেকেই যোগাযোগ করছে পার্সোনালি, স্পেশালি যখন শুনছে সবাই যে ম্যাডাম প্রফেসর রশ্মি সরকার ইজ দ্য স্পিকার, এই জন্য সবাই স্পেশালি আবার আমার সঙ্গে যোগাযোগ করছে। অনেকেই এরকম আছে যারা ম্যাডামের বই পড়েছে, যারা ট্রেনিং করেছে, তাদের অনেকেই আমার সঙ্গে যোগাযোগ করেছে সরাসরি। আনিস, ওয়েটিং রুম রাখেন করো, সরাসরি ঢুকে গেলে তো ভালো হতো।
আর ওয়েটিং রুমটা সেটিং থেকে ওয়েটিং রুম বন্ধ করা আছে, বাট সামহাউ কিছু একটা সমস্যা হয়েছে, এখান থেকেও ঠিক করতে পারছি।
আচ্ছা ঠিক আছে, অসুবিধা নেই, আমরা দেখি থেকে।
ব্যাডের প্রেসিডেন্ট কে ডক্টর সিকদার।
ইয়েস স্যার।
ডক্টর সিকদার এন্ড সেক্রেটারি আপনি হচ্ছেন?
জি স্যার।
আচ্ছা আচ্ছা।
জি ম্যাডাম। ম্যাডাম, হোয়াট অ্যাবাউট ইওর পোলিং? চলছে পোলিং আপনাদের, তাই না?
হ্যাঁ, ওটা 1 তারিখ থেকে শুরু হয়ে গেছে and it will go on till 15th of November, quite long actually. Some people might enter.
Yeah.
देखिए, थोड़ा हेयर पैक नहीं, डैंड्रफ वन पार्ट है। अगर स्कैल्प अच्छा नहीं होगा तो बाल भी पतले और हेल्दी नहीं होंगे, वो वन पार्ट है। बट इनका जो ये डिस्ट्रीब्यूशन है जो कम होने वाला, इसे कहते हैं फीमेल पैटर्न हेयर लॉस।
আনিস, দুজন ঢুকতে পারছে না কেন জানো, দেখলাম যে।
আমি স্যার ম্যানুয়ালি ঢোকাচ্ছি সব।
আচ্ছা, অসুবিধা নেই, করে নেন, আমি করছি। আসসালামু আলাইকুম আপা। আমি দিচ্ছি।
Not yet started. হ্যালো সাইফুল, দেখো তোমার কতজন হয়েছে, শুরু করা যায় কেন?
শুরু করে দিব স্যার, 60 এর উপরে হয়ে গেছে স্যার।
হ্যাঁ, শুরু করে দিবা। হ্যাঁ, টাইমলি শুরু করে দাও।
জি স্যার, শুরু করে দিব। তো আমরা প্রায় 70 হয়ে গেছে। আমরা
ভেরি গুড। 100 এর উপরে যাবে, অসুবিধা নেই।
150 মতো হয়ে যাবে।
হ্যাঁ,
আনিস, আপনি ই করেন, হ্যাঁ, এটা কন্ট্রোল করেন, হ্যাঁ, এটা ওয়েটিং রুমটা। যেহেতু
জি স্যার।
ওকে স্যার, শুরু করে দিলাম।
হ্যাঁ শুরু।
স্যার 2 মিনিট একটু
আনিস, আপনি একটা ওয়াচ পার্ট দিন আমার।
লাইভে যাওয়ার জন্য আমার 2 মিনিট সময় লাগবে।
আচ্ছা, আমি বলবো এখন, একটু আমি একটু করে নেই।
আচ্ছা,
ম্যাডামের এটা Good evening and welcome from Bangladesh Academy of Dermatology. Here we are in the 16th BAD webinar. We've started the Bangladesh Academy of Dermatology webinar in the early part of the pandemic. Day by day, it is the 16th one. We have got many of the national and international renowned dermatologists and professors, our honorable teachers of both Bangladesh and India were with us. Professor M. Ramam of AIMS, Professor Subrata Malakar, Professor Dr. Mohammad Shahidullah, Professor Dr. Rashid Mohammad Khan, Professor Nurun Nabi, Professor, and many of the Bangladeshi professors were here in different times. And now today we have an opportunity to learn from a renowned professor, Professor Dr. Rashmi Sarkar of New Delhi, India. I will again welcome you all dermatologists of Bangladesh. Right now, we are 100 dermatologists from all over the country and many of our from India. Welcome again. Before starting our today's webinar, I want our president, Professor Dr. Mohammad Shahidullah Sikdar sir. Professor Shahidullah Sikdar is our president, and he is an honorable ex-Pro-Vice Chancellor of Research and Development of Bangabandhu Sheikh Mujib Medical University and Chairman of the Department of Dermatology, Bangabandhu Sheikh Mujib Medical University. I welcome everybody and request Professor Dr. Mohammad Shahidullah Sikdar sir to give a short welcome and introduce the organization and permit the starting of the today's webinar. Professor Mohammad Shahidullah Sikdar sir.
Thank you, Saiful. First of all, I welcome Professor Rashmi Sarkar, renowned professor of dermatology in India, and in true sense, she is the renowned dermatologist in the subcontinent. We are very much delighted to present this very attractive dermatologist who has a lot of work, especially in cosmetic dermatology, and our dermatologists, especially the dermatologists of Bangladesh, they are very much eager to learn something and to see some procedures from Professor Lakshmi Sarkar. She is the professor of dermatology, Maulana Abul Kalam Azad Medical College of Delhi. And undoubtedly today's topic, the art of chemical peeling, it is very attractive among all dermatologists, especially to our young dermatologists. And you all know the cosmetic field of dermatology is occupying the most of the field of dermatology nowadays, not only in our Asian, I mean the subcontinent area, rather in the whole world, especially in the Europe and America. They are very much eager to learn and work on cosmetic dermatology. And chemical peeling is very attractive and fine. I mean this very, very important field of cosmetic dermatology especially. So today's topic, art of chemical peeling, is very important and attractive. We believe a renowned dermatologist from India, Lakshmi Sarkar, she is the authority in this field, and we are eagerly waiting to learn something from her, to hear something from her with modern and latest procedures of chemical peelings. And in our country, especially our young dermatologists are practicing it, and most of them are being exposed either in India or in Europe. So I believe our dermatologists would be very much beneficial to hear this today's webinar being presented by learned speaker Lakshmi Sarkar. I welcome and I will request Professor Lakshmi Sarkar to present her today's discussion and very attractive topics, art of chemical peeling. Thank you very much. Thank you. Our senior dermatologists, those who are participating in today's seminar, webinar, and young dermatologists, I will request everybody to stay with this connection up to the last of today's webinar. Thank you very much.
Thank you, sir. We are now 136 dermatologists from all over Bangladesh. I now want to introduce Professor Rashmi Sarkar. In fact, everybody knows, all dermatologists of Bangladesh well know Professor Rashmi Sarkar. He was first national secretary of Indian Academy of Indian Association of Dermatology and Venereology in the period of 2014 and 15. He is the president of IADBL Delhi State Branch in 2018 and secretary in 2011. First national IADBL Joint Secretary in 2012. He is the president of Pigmentary Disorder Society of an Indian Women's Dermatologic Association. He was editor-in-chief, Pigment International Journal. He was the co-editor of Asian Journal of Pediatric Dermatology. He edited 14 books, including Melasma, a monograph, and 186 articles, 75 chapters in different books. And he is the editorial board of 5 national journals, IJDVL, IDOG, IJPD, IJSTDS, IJD, and 5 international journals, ICD, JCID, IGWD, IAD, and dermatotherapy. And 70 international and 150 national faculty lectures. He has that experience, a lot of experience in the field of academic dermatology. He is the chair of International Mentorship Committee, ISD. He was the international position like Vice President of International Society of Dermatology, ISD. And is the board directors of Asian Society of Pediatric Dermatology, Women's Dermatologic Society, and member of International Affairs Committee of American Academy of Dermatology. He's the awards. He's got awards like oration received from Dr. B.M. Ambadi oration in 2019, Dr. B.V. Satyan oration, and Dr. Madhusudan Das oration, Economic Times Inspiring Dermatology Award 2019. It's our opportunity, great opportunity, get Professor Rashmi Sarkar in this 16th EAD webinar. I thank Professor Rashmi Sarkar to give our that opportunity. And I now request Professor Rashmi Sarkar to deliver his today's speech. Madam, Professor Rashmi Sarkar, how do you feel with Bangladeshi dermatologist here today?
Yeah, good evening, everyone, and a very warm namaskar. And I think it's a wonderful feeling to be here finally, because I must tell you that I almost had the opportunity to come, twice or thrice. For some reason or the other, I could not come, last minute. So definitely it's a pleasure today. I think COVID has been a bad year, 2020, but it has also done some good things. There has been a lot more exchange, online exchanges, and these programs. So that is the good part of our program. So I'd like to first of all thank, Dr. Sikdar as well as Dr. Saiful Bhuiya, because they invited me, for this very prestigious Bangladesh Academy of Dermatologists webinar. This was also on my list. I have not done it in Bangladesh. I've done it in most of the other countries in Asia. This was left. And Bangladesh is always very close to our heart. And the other thing is I have many friends in Bangladesh. Fatima Wahida, I think, who's really been reading my book. She keeps on writing questions. And there are other people like Dr. Zeenat is there, Dr. Sarkar Mehboob, just to remember some names. We have been meeting each other in conferences. Everybody is very warm. And I'm sure that, this may be my first, but I'm sure that there'll be plenty of more, exchanges in the future. So with that, I'm going to talk about chemical peels, something which I had started doing way back in 2000, 2001. It was very new at that point of time when I was in Government Medical College, Chandigarh. And that was my paper in 2002, which was published in Dermatologic Surgery, which actually caught the eye, of a lot of people, and a lot of papers were made on the basis of that. So we are going to talk about the art of chemical peeling, what's new. It's not just an art, it's an art and a science. So we're going to talk about both of them. And I've actually changed now, to Lady Hardinge Medical College. That's also another college in Delhi, right? So is my screen visible?
Yes, madam.
Okay. So chemical peeling, it is an accelerated form of exfoliation, and this is used by the use of a chemical cauterant or escharotic agent on the skin. So basically, it's a form of controlled wounding of the skin. This is then followed by resurfacing of epidermis. In the resurfacing, that is the time when the melanocytes are shed off. Remodeling of the collagen and elastic fibers, this happens in the dermis, and deposition of glycosaminoglycans. So what happens is, overall you get a skin which looks much more rejuvenated, and hence it looks much more lighter. That is what it does to the skin. So what are the advantages here about the chemical peel? A lot of young people like doing it, and not just young, even people who are senior like doing it. This is a relatively inexpensive and safe office procedure. Now, when I say inexpensive, as versus lasers, it is less expensive. It requires minimal technical expertise, but you have to learn the do's and don'ts. This is an extremely popular treatment modality for melasma and post-inflammatory hyperpigmentation. However, remember that the most disturbing complication in dark skin patient, that is people like us, skin type 4 and 5 mainly, there can be post-inflammatory hyperpigmentation. So we have to beware. So what do we need is need for a good pre-peel and maintenance therapy. That is what I'm going to be talking to you also. So let's have a look at the classification of the agents. Now, what I have marked out in blue are mostly what we do in the subcontinent. I think even you people may be doing. These are the traditional or conventional peels. What is there in brown is just to complete the list. This is conventional or mono peels. So what is recommended for dark skin like ours is the very superficial peel, which causes a wounding till the stratum corneum, and superficial peels, which causes a peeling till the entire epidermis. The medium depth peel, which goes till the papillary dermis, is restricted. We do it in only few very well motivated patients in the hands of very experienced dermatologists. And deep peels, which goes to the reticular dermis, is something which is a big no-no in our kind of patients. Let's have a look at very superficial peels like TCA 10%, glycolic acid 20 to 50%, Gessner solution 1 to 3 coats, tretinoin and salicylic acid 10 to 20%. Superficial is TCA 10 to 30%, glycolic acid 50 to 70%, Gessner's 4 to 7 coats, and salicylic acid 20 to 30%. Remember that when you're doing more coats, it starts becoming from a very superficial to a superficial peel. What about medium depth peels? There are many. Mainly this is for fair-skinned patients, which we have in the West, and something that we can use and improvise is glycolic acid, 70%. And out of the other peels, if you're doing Gessner's plus TCA, use 25%, not 35% like Monheath's. Glycolic acid 70% plus TCA 35% or Coleman's is something we can improvise. We can make it as 25% maximum. And again, deep peels till the reticular dermis for phenol peel and Baker Gordon's phenol formula is not something that we would like to do. Now, there are a whole lot of newer peels now in the market. What are they? Some of these are single agents, some are combination peels. They are no longer the conventional peels, and some of them are proprietary peels. So, single agents, I'm talking about that which has some evidence, is lactic acid, mandelic acid, pyruvic acid, and tretinoin peels. Combination peels are salicylic mandelic, salicylic lactic acid peels, phytic acid combination with alpha hydroxy peels, arginine amino acid combination peels, tretinoin peel combinations. Several proprietary peels in the market. What is a proprietary peel? You may know the total content of the acids. Exact composition is something which only the company would be having, but nevertheless, these are quite safe. And sequential peels, when you do one peel after another. So some of these are the newer and proprietary peels. All may not be available. They are available in different countries, but yes, these are peels which are more aesthetic, like the azelaic acid peel, polyhydroxy, ferulac, retinoic, enzyme peels, obagi blue peels, and so many other peels which are available. And you also have the party peels. What are these new peels or the proprietary peels or commercially available peels? Remember that they are in the form of nano emulsion or micro emulsion form, so they are better accepted. They also contain moisturizers, additives. So when you look at the label of a jar, you may not be reading all peels, but you're looking at additives. So in the powder form, there is salicylic acid, aloe vera, ascorbic acid, grape polyphenols, nicotinamide, kojic acid. When you look at the percentage and it is less, these are additives. It's making it more acceptable cosmetically. Gels like ascorbyl glucuronide, centinella, astralc extract, 15% lactic acid, and so on. So these are not peels, these are additives. So they are type of cosmeceuticals. pH which is more tolerable. So remember that The more acidic a peel will be, it's going to be much more potent, but we don't want it to be so strong. And finally, these are buffered agents. That is very important. So in the new technology, you have the gel-based peels. What are gel-based peels? So these again work on thixotropic activity. So what is thixotropic activity? Certain gels become fluid on mechanical stress and return to semi-solid state on standing. So they're kept in bottles and very easy to keep. The change in pharmaceutical formulations of peeling agents determine their slow release. For example, you'll find that the combination of salicylic acid 20% and mandelic 10% in gel form, this is always available. Advantages are easy application, less dripping. You have to be very careful when you're doing a peel, when you're especially a fresher in peels, because if there's a dripping, that's going to leave behind a lot of post-inflammatory hyperpigmentation or scars. So what are the newer peels with enhancers? We often hear of companies telling you this is an enhancer. Now, addition of enhancers in a peel gives an additive effect and also helps in creating customized peel for some indication like kojic acid, retinol, citric acid, arginine. So what does it do? Some of these are being added for the hypopigmenting agent or as an anti-aging effect, and it's making it, it's like adding on more cosmeceuticals to the peels. So some general definitions: combination peels when 2 or more peeling agents are present in a same formulation, for example, salicylic acid, mandelic acid peels. What are sequential peels? More than one peel is used one after the another. Why does this happen? These are usually incompatible peels. They cannot stay with each other, and it cannot be formulated as a combination peel. So I've already talked about this. Sequential peels also I've already talked about, and they're not compatible with each other. They have different neutralizing way or pKa. What about segmented peels? This is using different peels in different cosmetic units in the same session and same patient. Choice of peeling agent depends on indication, severity in different cosmetic units and skin type. For example, supposing you have an area that is with acne and you also have periorbital pigmentation, you may want to combine in the same session. Maybe you may want to do a salicylic acid peel, and in the periorbital area, you may want to do a kojic acid peel or a lactic acid peel. So that is segmental peel, using it in the different segments. Switch peels. When peels are changed serially in different peeling sessions, they are called switch peels. Start with one peel and then move to another peel, depending on the patient improvement and indication. For example, we start a peel for acne, then acne is removed, PIH is there, the peel is gone, the PIH is gone, maybe then we are left with a scar. So we can keep on switching the peel from one to another. So salicylic peel for acne, followed by Tricyst for the pigmentation, and then a TCA cross for the acne scar. There are just many chemical peels. They're all available in my book, which I'll show you later. And it's depends from country to country, or you have to just order them, on Amazon. There are many of them. This is just to give you an idea that there are different permutation, combination may not be possible to remember all, but you have many. Some of these which are between superficial to medium are some of the phenol peels. Now the phenol peels in our kind of setup are not the ones with croton oil, mind you, because croton oil is an irritating agent. So we should not use it in dark skin patients. So these are peels, if you notice, which are more of 15% TA, glycolic acid, phytic acid, ascorbic acid, and so on and so forth. They are combinations. So what are the indications for chemical peeling? Most important is pigmentary dyschromias like melasma, post-inflammatory hyperpigmentation, lentiginous, and ephthalites. Acne like acne vulgaris, acne excori, post-acne hyperpigmentation. Aesthetic like fine wrinkling, photoaging, and dilated pores, because dilated pores can again look quite ugly. Then this is important. What are the factors that is which affect, the working of a peel, depth of the peel? Remember that you have to know the type of the peeling agent. You should be confident that you're using this, you know everything about the properties. Concentration of peeling agent, always better to start from a lower concentration. As we go up, remember, if you are going, you're working more towards a medium depth peel. So be careful. pH of the agent again, always have a good, buffered agent. Number of coats applied. I already told you that maybe it is best to do one and then, the second coat just in the affected area. When you're increasing the number of coats, even the depth can increase. Then you have what you call the technical variables, technique of application, how the skin was primed, how was it cleaned and degreased, was it very vigorous? Skin type and ethnicity, anatomic site, duration of contact because you don't want to keep it for a longer period of time. And finally, the amount of actinic damage that is in photoaged skin. So this is important, pre-peel preparation or priming with topical agents. Why do we need priming with topical agents before we do a peel? Advantages are, it allows for more uniform penetration of the peel. It accelerates reepithelialization, reduces the wound healing type. Skin lightening effect is there because there's a dispersion of the melanin granules and enforces the concept of maintenance regime. So you're already starting off with a priming agent. You're building up the skin a bit and you make sure that we have something as a maintenance regimen in between the peels so that there is more of a lightening effect and it is maintained. So what are the agents, priming agents? Broad spectrum sunscreens, important, at least an SPF of 30 plus, and use the ones with inorganic sunscreens also. Hydroquinone 2%, 4%, tretinoin in our kind of a skin till 0.05% is good. A combination would also work very good. Remember, when you're using hydroquinone, at least 2 to 4 weeks is the minimum time required for priming to be really good. And glycolic acid 10% is again a very well accepted agent. You can really use that. What are the adjuncts or the priming agents for chemical peels? These are two studies that we did when I was in the Department of Dermatology at Maulana Azad Medical College. Now I'm in Lady Hardinge. Well, one was what we had done was that is it was done on TCA peels, serial TCA peels, as well as group 1 and group 2 in which, hydroquinone and tretinoin both were used as priming agents. And what was noticed here is whether we do it for serial trichloroacetic acid peels or serial glycolic acid peels, results are better in group primed with hydroquinone compared to tretinoin. And overall, it's also good for the post-peel hyperpigmentation. So of course, this is the peeling procedure. And it's very important that, this is how we do it. It's very important that you make the patient lie down. The upper end of that is the head of the table should be raised a bit. A cap is good. If possible, you can put, patches over the eye. Always cover the corners of the eyes, nose and lips with Vaseline. You can do that with a baby bud. And then after that, a cleaning is pretty good. A cleaning could be done with your spirit, or you can use, any of the cetyl alcohol also for cleaning. And you can use acetone for degreasing. Remember that 2 coats of cleaning and 1 of degreasing is good enough in most of the cases. And it should be firm so that some dirt really comes out. After that, you can apply the peel. There are various ways. This is with a brush, but you can also use the baby buds which are there, the earbuds which are there, or you can even use a nice cotton ball. When it is more of a liquid peel, use more of the cotton ball. When it is a gel peel, again, it works well with the baby bud or the brush again. So strokes are applied in the units, the forehead, the cheeks, the chin, then the perioral area and the perinasal area. These are very important. And you may want to do feathering also. Lastly, feathering of the chin, feathering of the area that is, the hairline area, that is very important, just as you use foundation. And you can terminate according to the peel with water. And after that, it is good that you make the patient wait, use a sunscreen, and then go back home using only a mild cleanser, a sunscreen, and bland moisturizers. Use of maintenance therapy is important. So as I told you, any of the skin lightening agents can be used. Interval between peels depends on the peel. It can be from 1 to 3 weeks. This is just a table peels that can be used for melasma, hyperpigmentation. Priming is very important. Sun protection is also there. When you have primarily epidermal pigment, when it is more of brown pigment, then you could use a single agent like salicylic acid, tretinoin, glycolic acid, SM peel, kojic acid, and so on. Or you can combine these. Maintenance can be done with tretinoin, kojic, arbutin, and also a broad spectrum sunscreen. When you have mixed kind of, melasma or hyperpigmentation, epidermal and dermal, use a combination. It could be a glycolic plus kojic acid, salicylic plus tretinoin, TCA, or whatever it is, and then you maintain with one of the skin lightening agents. Dermal pigment doesn't respond very well to peels. You'll have to remember that. And again, if you're using any of the peels like salicylic, tretinoin, glycolic acid in the higher concentration, or TCA in sequence or rotation, only for the epidermal component. Lasers you may have to use also in addition. Maintenance, it's with the skin lightening agents, that is also more for the epidermal pigmentation. You could combine with the tranexamic acid now. So what are the contraindications? These are not absolute. They have to be individual. So infections like active viral, bacterial, or herpetic infection, you may need to treat. Open wounds, never do a chemical peel, it can wait. History, that is drugs with photosensitizing potential. For medium and depth peels, not for superficial peels. Abnormal scarring, keloids, atrophic skin, isotretinoin used in the last 1 month, these have to be ruled out. For inflammatory dermatosis, psoriasis, atopic dermatitis, better not to use. There could be cobnerization or the skin can be very dry. Patient nature, very important. If you have a uncooperative, unrealistic patient, please be very careful when you take up, because you cannot promise magic, to the patient. You have to tell the patient that this is just a second line treatment. So these are what you can have. That is when you're starting off your clinic: the brush, earbuds, ice packs, gloves, because you can use water or ice packs, cotton balls which have to be there, petroleum jelly, that is water-filled syringes, cap, beaker. Then again, measurers, handheld fan can be there, but be careful again, don't meet with an accident. A timer or your watch is good. Alcohol and acetone. So first of all, the alpha hydroxy acids or the fruit acids, these are the non-toxic organic carboxylic acid. They're quite versatile. Glycolic acid, lactic acid, malic acid, tartaric acid, citric acid are present. Well, this was a study we did, a controlled study on Indian patients. In group 1, modified Kligman's regime was used. And we of course used the one which had 1% hydrocortisone. And in group 2, we gave modified Kligman's regime plus 3 cereal 30% and 40% glycolic acid peels each at 3 weeks interval. There was a significant decrease in the melasma area and severity score. The peel side had a rapid and greater improvement. So this shows that a combination works better. We gave it for a period of about 18 weeks. So the one on the top is melasma at baseline. The one in the bottom, again, as you know, that is, there is a lightening which the patient found as very good, and so did the dermatologist. And this is after finishing 6 peels with modified Kligman's regime. So what about salicylic acid peel? This is a very versatile peel, one of my favorites. And it's found in a wide variety of combination. There's a dearth of studies in darker skin types. A pilot study in darker racial ethnic groups was done. This was by Dr. Pearl Grimes. In that, she examined 6 patients of melasma where 20 to 30% salicylic acid peels were done at 2 weekly intervals and found to be effective and safe. What is nice here, these are of course patients with acne, scars as well as, acne and post-inflammatory hyperpigmentation. The good part about salicylic acid peel is it has the pseudo frosting, a very nice end point. Like glycolic acid has a redness or a burning. This has a very nice, pseudo frosting. You can see the lines. And so there is a nice end point when you can terminate the peel. We also tried, 20% salicylic acid peels in periorbital hyperpigmentation. Again, patients don't like the very tired look they have. So if it is epidermal pigmentation, we have treated with 20% salicylic acid peels in one group of patients. This was published in the Indian Journal of Dermatology. And although the lightening was somewhere around 40 to 50%, the patient was pleased with the change in appearance. Well, again, if you look at, the the lactic acid peels, these are members of alpha hydroxy acids with a similar activity to glycolic acid. Well, one study from the Middle East showed that full strength lactic acid solution, this was of course higher, 92% with pH 3.5, was used in 20 patients with melasma with skin type 4. Pure lactic acid peels were done every 3 weeks for 6 sessions. There's a significant decrease in the Massey score. Now, this is a higher concentration lactic acid peel. Half a concentration is available, and this is a much lighter peel and can be used for maintenance. So when you find that there's a sensitive skin, there's an issue again with the pigmentation and you're doing it with the glycolic acid peel, after doing 6 glycolic acid peels, you can definitely start off with the lactic acid peels because you can use these as nice maintenance peels. Tretinoin peels. Now, this was a study that we did, which was published in Dermatologic Surgery. We used it raw, but tretinoin is available in many combination peels. So this was a split phase study on 10 Indian female patients with melasma with serial 1% tretinoin peels, which were done weekly, while 70% glycolic acid was applied on the other side for 12 weeks. There's a significant decrease in the modified Massey on both the sides. No statistically significant difference was seen between the two sides. So this showed that 1% tretinoin peel worked quite well, over these 12 weeks done every time along, whereas 70% glycolic acid was done on the other side. So this is the right side and the left side. The right side, of course, had an application of the 1% tretinoin versus the 70% glycolic acid peel. And this is after 12 weeks where both were found to be pleasing in their application. Now, regarding the newer combination peels, I'm just going to mention the studies. This was a study done by us, published in Dermatologic Surgery 2009, where 44 patients of acne with post-acne scars and post-acne hyperpigmentation were divided into 2 groups, 35% glycolic acid versus 20% salicylic acid, 10% mandelic acid peels. 6 sessions were done at 2 weekly intervals, and salicylic mandelic peel was more efficacious for active acne and post-acne hyperpigmentation. Now, the SM peel was also better tolerated. Remember, there's salicylic acid and mandelic acid is a large molecule. So the penetration is very slow. You have lesser side effects, but you have better hypopigmentic effects. So again, this is with the salicylic mandelic acid peels, 6 peels, and this is with acne. And this is before and after 20% salicylic, 10% mandelic is. Hello, can you hear?
Yes, ma'am.
So 30% salicylic acid in newer formulations. What do you have here? Beta lipohydroxy acid. So this again, these are newer derivatives, a derivative of salicylic acid, beta hydroxy, lipohydroxy acid up to 10%. Is widely used in Europe. This is also being marketed in other countries with increased lipophilicity and keratolytic effect. The pH is similar to normal skin, pH 5.5, and has proved to be quite tolerable. There's an issue. I don't know, it's not moving forward. Okay. Okay, so here again, this is about phytic combination peels. So what are phytic combination peels? These are combination peels, and the total, concentration of the acid is 50%. That's what I told you about proprietary peels. This is a slow release commercial proprietary product composed of phytic acid, glycolic acid, lactic acid, and mandelic acid. So it's a combination. These are slow releasing peels promoting continuous penetration. Antioxidant properties are what phytic acid has, and it reduces the post-peel inflammation caused by other hydroxy acids. So it's a peel, it's also an antioxidant. There's marked tightening and anti-tyrosinase effect also. So that is something which is very important. So this is a study that we did, published in Dermatologic Surgery, the comparative, that is evaluation of glycolic acid, which is a conventional single peel, salicylic mandelic, which is a combination peel, and phytic acid peels in melasma. So 90 patients were enrolled in the study. 72 patients completed the study. 18 patients dropped out from the study. In group A, there's a glycolic acid, 26 patients. Group B, salicylic mandelic peels, 24 patients. And group C, phytic acid combination peels, that is 22 patients. So these are the colors. The glycolic acid is blue, red is salicylic acid mandelic, and easy phytic combination peel is the green one. So when you look at from the baseline till the 12 weeks, what do you find? You find that the decrease in the lightening is comparable, both glycolic and salicylic mandelic, but it is little less or slow in easy, the phytic acid combination group. What about the side effects? Well, side effects appear to be more in the conventional peels, the blue lines, which is the glycolic acid as compared to salicylic mandelic or phytic combination peel. So there's erythema-induced squamation. There's post-peel, pigmentation or persistent erythema. All these are definitely much more in the glycolic acid peel than in the other peels. So if you look again, this is the glycolic acid group and A group, and this is before and after doing, a group of 6 peels. So there was a lightening that is in the melasma. Here again, this was a salicylic mandelic group, and this is before, and this is again after doing 6 groups of salicylic acid peels. And finally, the phytic acid combination peel, which was a proprietary peel, and this was before and after, that is doing 6 peels. And this is something which is very good for a maintenance regime if it is available. So this was one, good peel, which is a proprietary peel. What about some other peels? Combination yellow peel, which is a combination of retinol, salicylic acid, phytic acid, kojic acid, azelaic acid, vitamin C, and bisabolol. Bisabolol has moisturizing properties. So there's increased collagen synthesis, and it inhibits collagen degradation to improve wrinkles. That is why it's used in anti-aging. Improve initiation of epidermal proliferation and differentiation improves the smoothness, and inhibition of melanosome transfer and tyrosinase activity improves the dyschromia. Baker-Gordon's formula is something which is 88% phenol, 3 milliliter, croton oil, vesicant, 3 drops, and hexachlorophene or Septisol soap solution, 8 drops, in distilled water, 2 ml. Remember, this is very irritating for dark skin in us, and there's a deep penetration and absorption of phenol, so this should not be used in skin type like us, but only in fair-skinned patient. Well, there are many peels. When we talk about phenol peels, we are talking about the modified phenol peels. I don't want to talk about any brands, but this is just to give you a description. So again, the phenol, based peels, the lighter ones, they have 8 to 15% of phenol. So this is not 88%. TCA 15% and glycolic acid, very less 2%. What else? These are the additives: ascorbic acid, phytic acid, ferulic acid, salicylic acid, retinoic acid, vanillic acid. So these are acting ferulic acid as an antioxidant and a very light peel. Then again, the other peels, different concentrations are there in phenol light 8% or 15% or 15% phenol with 3% alpha arbutin, 2% kojic acid, and even up to 25% phenol. So here it's an anti-aging, improvement in texture and pigmentation following 4 weeks, that is of the lighter phenol peel. So this is before and after. So what we see here is the texture and the post acne pigmentation which is there after using these phenol peels. You need a little stronger peels. Here again, these are the results again with the phenol lighter peels which are available before and after doing these peels 4 weeks. Sorry, 4 times, not 4 weeks. And again, these are 5 sessions of 3 weekly phenol light peels where there's improvement in texture and pigmentation again. So you need a little stronger peels again. So here again, these are also there, that is active acne, and you're using that is before and after some of the phenol peels which have TCA in them. And you have many fancy peels like the derived black peel. What is the black peel actually that is being used for acne by some people? It's basically derived black vinegar, acetic acid, salicylic acid, jasmonic acid, potassium iodide, lactic acid, citric acid. So what does it do? This the vinegar actually acts on the active lesions of acne. So here again, there is an improvement, as you can see, that is on applying, that is the black peel which is there. And you have many other fancy peels. You have lactic acid. These are more of cosmeceuticals. Milk peels and all these are used more as party peels because they are lighter peels, more of cosmeceuticals. And then again, before and after, so you have different kinds of, hydroxy, alpha hydroxy peels added to them. Well, what are the combination therapies that you can do? The combinations you can do with them are microneedling, lasers, botulinum toxin, fillers, and subcision. So again, this is something that you can do. You'd have to be very careful when you're doing them. You have to do them one after another. Finally, what are the complications? Now you have to remember one thing, that when you're using very superficial and superficial peels, complications do not occur that easily. But for a newcomer, you have to be careful because if you get a complication, you have to do a lot of hand holding. So post-inflammatory hyperpigmentation can occur, post-inflammatory hypopigmentation, persistent erythema, that can be a marker of scarring. So please be very careful. Scarring can occur in medium depth peels. Infection is another thing. If there's a little wound that is being formed, then infection can occur. Finally, allergic reactions, if you're allergic to any one component of the peel. So what are the conclusions? There is a need for randomized controlled trials with longer periods of follow-up to assess the efficacy of chemical peels in melasma and post-inflammatory hyperpigmentation. Remember one thing, we usually have studies with mixed type of ethnicities. Skin types are not uniform. Even the methods of measurement are subjective, not objective. Very superficial and superficial chemical peels used in combination with adjunct topical therapy are efficacious and well tolerated in dark skin patients. Careful patient selection, treatment by an experienced dermatologist, a good pre-peel and post-peel regime are very important for good results. So before and after care and patient selection is very important. So Before I wind up, this is my book, Chemical Peels, A Global Perspective, which I have co-edited, that is edited with Dr. Wendy Roberts from USA. And this is available at JP Brothers Publishers if you go to their website, or also at Amazon. This is the book, and I'll just stop the share. This is the book which is available, and you know, I think it has made a lot of difference to the practice of chemical peels in India, both in the remote places and the cities. And I'm sure that many of the people from Bangladesh have also liked it very much. Thank you for all the respect and affection, given to the book. Thank you very much.
Thank you very much, Madam, for your nice deliberation. In fact, everybody was such attentive that all have forgotten to put any question. In fact, everybody was attentive. I have some question from Professor Abdulmia sir. Abdulmia sir, Adab Professor Rashmi Sharkar, I'd like to know your experience about outcome of chemical peeling in case of melasma. Madam, outcome in melasma.
See, as I mentioned, chemical peeling in melasma is at best, a second line treatment, isn't it? That's what I mentioned, that it is a second line treatment. So you'll have to actually first give a topical therapy, that is, I didn't show the algorithm there, but best is first we go in for a topical therapy. It could be either the triple combination or one of the monotherapies, and we only add up a chemical peel as a second line treatment. It is well accepted in melasma. The only thing is you have to know that after giving a certain number of peels, say that if you have given 6 peels and it's just not working, then there is no point in giving it. You may need to change the peel, or you may have to change your regimen or your concentration. Otherwise, it's a good agent for melasma, but again, I'll say it's an adjuvant, it's a second line therapy. It works very well with topicals.
Thank you, Madam. Madam, today we was more than 200 dermatologists here with you.
I saw that, yes. That's very nice.
Yeah. One question, what agents or technique are needed for peeling in persons having tendency of excessive post-inflammatory hyperpigmentation?
Post-inflammatory?
Those people who have tendency for excessive post-inflammatory hyperpigmentation, is there any cautions to take?
Okay. See, one thing you'll have to remember that when you have post-inflammatory hyperpigmentation, you're more likely to get that. You can always examine the patient and see. A very good priming agent, okay? So when you're using the priming agent, if it is for a patient is going to be post-inflammatory hyperpigmentation is more, use something which has a hydroquinone and a tretinoin combination. So you can give both, one after another, and use a hydroquinone which is at least 4%. And I would say, please use it for 4 weeks. Now there is an advantage in that. It's also acting as a part of your treatment. It's also acting as priming. So, Dr. Bonheat always said that for priming with hydroquinone to be perfect, 4 weeks is the best time. 2 weeks is only if you do not have enough time. So you have to do a very good priming. Also, always stick to a lower concentration. Like if you're using a glycolic acid, I would not like to use, more than 35% of glycolic acid. And after that, very stringent sun protection, photo protection, which is important. Use a very good topical agent, which could either be a triple combination cream, or you could use, hydroquinone or kojic acid after that. So you can minimize your post-inflammatory hyperpigmentation, but sun protection, very important.
Thank you very much, Madam. And one question. Do you need any pre-procedure laboratory test in any situation in chemical peeling?
Well, not really. See, unless there is some kind of a concomitant medical condition, but even then, chemical peeling is that way quite safe, your superficial peel. So even if you can't give a topical or an oral agent, remember that peeling is something that you can actually do, So there isn't much of an issue in giving that.
Okay, thank you. Does test spot testing routinely needed?
Yeah, that is a good question, because you see, there are patients who are very impatient, you know.
Yeah.
So you may need to, you know, straight away start off with a peel. And so, because otherwise, if you do a spot peel, you know, you have to wait for a week and then call the patient and do it. That is there. Having said that, I think there is no harm in doing a spot peel, because one thing is that the patient is also seeing that you're testing, you know, in a way for safety. Now, tomorrow, for some reason, there is some kind of a complication that has occurred, because remember, this is very unpredictable. It looks like a very easy process, chemical peeling. It just looks that what is it? It's just a chemical. But you know, the skin is unpredictable. You may encounter sensitive skin while you're doing it, you know, and other issues. So at least if a test is done, I think as a dermatologist, you're quite safe that you have tried it out once, the patient has seen it, and whatever has happened is probably the patient understands that it is depending on the patient's skin, not on you. So although if in a rush you may not do it, still whenever you can, please do a spot peel. It's not a must, but wherever you can, there is absolutely no harm. You never know, like a salicylic acid peel. You may be sensitive, very innocent looking agent, but there could be a salicylic acid, you know, sensitivity.
Thank you, madam. Madam, many questions are here. Question from Mahima Momotaz. Good evening, ma'am. After doing a chemical peel, when can we do another procedure such as laser in the shortest period of time?
Dr. Mamima, you said, isn't it? Yeah. Good evening.
Mahima.
Mahima, yeah, good evening. See, the thing is, these things are very individual, you know, how you like doing it. But let me tell you, it's always better to be safe than to be sorry. So you've done one procedure. Some people may like combining. I don't think so. I think a minimum of at least 2 to 4 weeks, you know, if you can afford 4 weeks, it is fine. If not, at least between a laser and a peel, it should be at least 2 weeks, you know, that is the least you should do. But again, people do it. Sometimes you have to, the patient may not have that much of time, you know. Then you have to individualize. Please explain to the patient, take the consent of the patient, explain to the patient that things can go wrong when you're combining too many things, you know, together. So please give a gap of say about 2 to 4 weeks, you know, if you can.
Question from Dr. Sharmin Maria. What can be used in stubborn pigmentation and periorbital hyperpigmentation?
Good evening, Dr.
Sharmin Maria.
Yeah.
Maria.
Good evening. The thing is that, see, periorbital hyperpigmentation again is much more complex than your melasma. As it is, melasma is quite recalcitrant to therapy, but periorbital is even more. Why? Because it is of multifactorial etiology. We don't even understand its etiology well. Some of it is, you know, epidermal. When you have it, it is post-inflammatory due to atopic dermatitis or allergic contact dermatitis. Then you have a vascular pathology, which is due to the underlying blood vessels. You know, sometimes you can see that. Or it can be due to chronic diseases again, which is due to chronic renal failure or other chronic long-standing diseases, which is there. The fourth is the anatomic defect. So that is your tear trough defect, you know, or you have hollowness, you know, of the eyes and the nose. For that, the most definitive treatment is your fillers. In fact, you'd be surprised that probably the only treatment that has evidence in periorbital hyperpigmentation is probably the filler for the tear trough. That is totally different. If you have to use a topical because patient wants it to be better, sunscreens, a broad spectrum sunscreen is a must. I would say a moisturizer at night really works well. You'll be surprised that only using a moisturizer can do wonders. I like using the ones with aloe vera moisture, not raw, but aloe vera moisturizers, and use something like a kojic acid or a hydroquinone based, you know, cream, which is there, you know, around the eye. Keep it away from the eye. So that is something, that is the most lightest thing that you can do. If it is more dermal and you have like due to a blood vessel, then only something like a laser would work, but you're again very careful about doing a laser in this place. So that is what you should be doing. You can combine this with chemical peels. This is an area again, although this looks very soft, but you can do a chemical peel. So what kind of chemical peels again? Kojic acid peels would work better. Use something which is a softer peel and something that contains lactic acid or mantelic acid. That works very well in this area, or something with tretinoin, because you also have, anti-aging, which is seen around the eyes, as well as, periorbital darkening. So it's very complex. It is depending on the etiology.
Thank you, Madam. Madam Rekha Prasad, good presentation, Madam. What does milk peel contain? How does it work? Milk peel.
Milk peel has, a combination of, things, including the additives, but basically it has, lactic acid and, other combinations with that. That is what gives it the name of, a milk peel. These are fancy names. You'll find, lots of very nice named peels which are there. That's what I said. You have black peel, you have milk peel, they all look very fancy. But you have to know the name, because basically what works the best is our conventional peels. Why? Because that was the science. Now what we have are aesthetic peels. So they don't work so much, but they are very well tolerated. So you want both. You want tolerance also.
Thank you, Madam. One question. What agent is best for a person with dry and sensitive facial skin, or in an atopic person? When we think chemical peeling in atopic person, what cautious should we take? Or what agent should be?
Yeah, see, the issue is, no matter what you do, in the peels, there will be some amount of dryness, because there is going to be flaking. Okay. And the skin also becomes a little sensitive. We all know that. We have seen that. So if you have a patient, say, of atopic skin or something, first treat, the dryness a bit. And it's good to use moisturization, before and after, a good moisturization. If you have to choose a peel, start with a peel, which is a lighter peel, something like a lactic acid peel. Because lactic acid peel is both a lactic acid chemical peel, it also has a bit of a moisturizing effect. So you could try using that, or you can use something like a lighter peel for pigmentation, like a mantelic acid peel, which again, as I told you, has a big molecule, so lesser side effects. Salicylic acid will definitely be very drying, so you avoid that, but use good moisturization before and after.
Same type question, if the individual is oily skin, then any caution or any technique?
Oily skin, again, some of us are naturally prone to have oily skin. So obviously salicylic acid is a very good peel, any kind of salicylic with combination, like whether you're using it with mantelic peel or with a lactic acid peel, it works better, for oily skin. But actually in real life, we have a combination. All of us have, some oily areas and dry skin. So it'll be more, indication wise, which is there. So I think you can use a salicylic acid peel.
It was long lecture from you, and I think you are already tired, madam. But so many questions are here. Which is party peel?
Yeah, so party peel, the word itself means party. Okay, so party means that something which is not very serious. So again, if you apply it to a peel, it's a peel again which is not very strong. Remember that. So what will it contain? It will be containing lower concentrations of chemical peels or acids. Also, it will have a lot of cosmeceuticals added to it. It's difficult to remember. That's why I showed you that there are different bottles with different things on them. What do? They don't really act very deep. They're not acting so much. At the most, what are they doing? They are just rejuvenating a little bit superficially. And that's the glow factor, which comes. And it'll just come and it'll go for some time. So you have, these are very nicely made. You have peels, you have powders added to it. So it's like, what should I say? It's a kind of a mixture between a cosmeceutical and a peel, so that it gives you a very nice rejuvenating, very nice glow peel, glowing effect which is there. So that is a party peel, a much lighter peel, so, and you find lots of them in the market.
One question from, there is no name. For axillary hyperpigmentation, which is your preferred peel? axillary hyperpigmentation?
Honestly, I haven't used, frankly, any peel, for axillary hyperpigmentation. That is one thing because you're talking about hyperpigmentation, not hyperhidrosis. I was wondering here. Well, it's a body pigmentation. When you talk about, so body pigmentation, so again, it's a softer area. So you can use something like, a mandelic acid peel, which is soft. Or again, you could use a lactic acid peel, which is there. It's going to be a lighter agent, but remember that axilla is a softer area. Otherwise, actually, any peel you can use. To avoid a TCA peel. Don't do a TCA peel, but otherwise you can use most of the other peels.
Dr. Mamoon, I have a question. Chemical peel and oral tranexamic acid, both can use in management of melasma at a time?
Yeah, definitely, Dr. Mahoon. That's a good question because, very often we come across dermal, melasma and dermal pigmentation. So tranexamic acid is one drug that can be used, for these dermal pigmentation. So it works better. I haven't shown you, I had a picture like, patient say of ochronosis, someone who's very resistant to other treatment of melasma, and that, we had used tranexamic acid for about 3 months, and we combined it with the phytic acid combination peels. So these are leave-on peels, self-neutralizing peels, and they can be kept over the night. So that was a nice thing that can be done, but definitely you can combine tranexamic acid with the peels.
Okay, thank you, madam. Question from Dr. Sailajai Chare. Which pill do you suggest for perioral hyperpigmentation?
There's no fixed peel like that, but again, it's an area which is soft and all. So you may begin, with a lactic acid peel, and then you can use a stronger peel if you like. Even a glycolic acid peel you can use, if you're interested, or a mandelic acid peel, because if it is just pigmentation, glycolic or mandelic acid peel can be used. It's an oily area again. So even a salicylic mandelic peel is something that can be used. So see the type of peel. If it is not much, use a lighter one like a lactic acid peel. If it is more, then use a mandelic acid peel. Mandelic acid is also a good peel.
Thank you, madam. Dr. Tanima Toma, very informative presentation, and it would be very helpful for the young dermatologists like us in clinical practice. Here, many are very young dermatologists, many are our students, and also our senior dermatologists also here. DAR, can we perform peeling immediately after derma planning?
After derma?
Planning? Not understand what is what are the therapeutic uses of chemical peeling other than cosmetic purpose? Therapeutic.
I think I showed there. Of course, you have things like actinic keratosis, seborrheic keratosis, and all that you can definitely use things like, TCA peels and all that. Those are the things which we have shown. Otherwise, scarring, acne scarring and all, that is another thing that, one can use, peels and everything.
Is chemical peeling contraindicated in patients with keloidal tendency, madam?
Yeah, there is the screen is, yeah. What did you say? I'm sorry, pardon me.
Is if any patient have keloidal tendency of develop
keloid,
yes. Then is it contraindicated?
See, when I showed you the books mention that it's contraindicated, actually it is not, For superficial peels, there isn't a problem. But if you're using something like a medium depth peel, then just be a little careful. You can still do it. But it is better that you're careful what kind of a peel you're doing, because medium depth peel, you have to be careful. You never know what turns out to be a, keloid, what becomes a hypertrophic scar or a keloid. So definitely. A lot of people are saying good evening to all of you. And thank you so much, because many of them are actually saying that very informative. So I'm just thanking them actually.
Okay, it is 9:10. We have some question more. Dr. Asbir bint Aslam. Good evening, ma'am. It was an awesome and very informative presentation. My question is, what is the duration of beneficial effect of salicylic acid peeling for acne or glycolic acid pill for melasma? And what should be our treatment plan after the beneficial effect of chemical is gone? Or what will be our plan to maintain the effect?
I think it's a very long question, so I'm trying to break it up, but I think what I understand is she's talking about probably the maintenance.
Yeah.
Once you have used, see, because chemical peels is something that, you know, one can keep on doing. Sometimes I've seen people, students, you know, suddenly they say that we have done 12, 18. And I said, if there's no effect, why were you doing it? That is when you come into the picture and you tell them and you take over. So I think you have to be very careful if it is not working, you know, for 6 peels and you increase the concentration for 12 peels, then I think that particular peel is not working. You may have to switch over to another peel or go in for a combination peel if that is not working. End point is as your pigmentation or, you know, your acne starts clearing. That is when you know it works. But please remember that peels don't work only alone. You have to combine them with something or the other, you know. So that is one thing. And end point, there is no end point, but you cannot go on and on. So after 12 peels, I would say give a break. That's a good practice. Give a break. Rotate with some other agents and it can come back again, because that means it's not working. And it's again, you know, you're using it as a placebo or something like that. I think somebody's asked Dr. Rekha Prasad.
Yeah, Rekha Prasad.
Asked something about lip pigmentation.
So many questions.
So she's asked about lip pigmentation. For lip pigmentation, there's no particular peel as such. You have to be careful. But you could use something like, you know, a lactic acid or a kojic acid peel. There is something that, you know, they did teach us that, you know, a phenol peel, but a phenol peel, you know, with croton oil, a modification that was actually published by Dr. Carlos Vambier, you know, in the Blue Journal. We have to look for that actually. So that he had used a medium depth peel, you know, he's used for the, a deep peel for the lips. But remember, if you do a deep peel for the lips, what will happen is the entire lip is, you know, the surface of the lip is going to totally come out. And after that, what happens is you get a healthier looking, lighter looking lip, you know. It used a combination of this phenol, Septisol, and, you know, certain other agents for doing it. You know, he had improvised it according to, you know, for the Indian skin. But the issue here is that the patient finds it very difficult to bear that, you know, when the entire surface of the lip is gone. It does come back better. So you can do a very deep peel for that, but I think we have to be very careful. You never know when the patient becomes impatient or something like that. So best is that you do lighter peels, like maybe lactic acid peels or kojic acid peels, because deep peels and medium depth peels can be done for the lips, but you have to have very well motivated patients, because you never know when the patient is going to take you to, you know, task, because we have to be very careful nowadays with patients.
Yeah. One question from Professor Dr. Mohammed Abdul Mia. If someone has used isotretinoin previously, what should be minimum time gaps before starting chemical peeling? Is it 1 month or 6 months?
See, for superficial peels, it is, you know, nowadays it's not so much of a contraindication. So 1 month should be enough for that. Some people have, for acne, sometimes they've also done it side by side. For superficial, it's not a problem. Medium depth peels, you have to be a little careful. Then it is a 6 months thing. Most of these things are actually for fair skin patients, and they're mainly for medium depth peels and deep peels actually. Superficial peels, it's not a problem most of the time, but still you could give a 1 week's, you know, 1 month's gap actually. You have to.
Many more questions are coming. Afroza Jasmine, Dr. Afroza Jasmine asked, is there any role of chemical peels in lichen planus pigmentosus?
Well, lichen planus pigmentosus always works best with, you know, medical therapy, as we all know. So, you know, it's basically, it's a subject by itself, you know. LPP is a full lecture, you know. So medical therapies you have to do. When do we do chemical peels? That is when the disease is burnt out, or in the later part when it is inactive. You know, when you stop seeing, maybe if you do a histopathology and the basal cell degeneration is no longer there. In the older, you know, what should I say, the, you know, inactive lesions, then you can do a chemical peel. This is where a TCA peel might work, or even the phenol peels which I mentioned, because those phenol peels are somewhere between superficial to medium depth peels. So they work well because it's a deep pigmentation that you have, exactly how they're acting, but they're a little bit deep. So maybe they have an effect, which is there, but some lightening is there with, medium depth peels. But again, you have to be very careful.
One our student, Afrina Jahan, ma'am, please share your experience regarding outcome in lentiginous.
I think lentiginous is again something which is quite difficult to treat again, it's a bit of a mystery. And, I would say that for lentiginous, if topical treatments don't work well, but if you would like to try something topically, something like tretinoin is a good combination. Sun protection, good sunscreens. Tretinoin, I like to also use azelaic acid. Believe me, azelaic acid is something 20% or 15%, gives a very good, effect on lentiginous. And if you have to use a peel, again, you could use, maybe the 15% TCA, which is there, combine it maybe with, one of the retinol peels. That is something that you can use. Ultimately, you will need the laser actually for these kind of pigmentation. But yes, short of a laser, you can try doing that. And it does work to a certain extent.
One, Dr. Rajashree Choudhury, a beginner, what peel we can use for treating melasma and acne in skin type like us?
I didn't get it, acne and?
As a beginner, I'm a beginner young dermatologist when they want to treat.
Well, for acne, yeah, it's always good that you try something like a salicylic acid peel. That works well. You can just try the single agent peel first, rather than trying any fancy peel or a stronger peel. So salicylic acid 20% is a good peel. It works very well on active lesions, also on the pigmentation. And for melasma, you could try something like a glycolic acid peel, but I would always say that going for a smaller concentration, a lesser concentration, like you could go in for 20%, then you could go in for 35% and so on. I would not say that go beyond 50%, because if you're doing that, do spot peels on that area, because glycolic acid looks very innocuous, but believe me, it's a versatile peel, but quite, it can sometimes be just out of your hand, the kind of reactions that occur. So I think it's versatile, but we have to be very careful. It can be very unpredictable sometimes.
Thank you, madam. It will be very helpful for all our dermatologists and students. Thank you again for your presentation. It was a very rich presentation. And now if you want to tell something for our dermatologists and for the Bangladesh Academy of Dermatology, and how was your experience, please share.
Yeah. So it's been an absolute pleasure, coming and, speaking to here at the Bangladesh Academy of Dermatology, because it's been as I told you, it was on my wish list. My mother's side of the family and, even my father's side of the family, originally they are from, some part of Bangladesh. That is how it is. Of course, we have never been there, because ever since I've been born on this side, born in Lucknow, brought up in Chandigarh and Delhi. But I think origin somewhere everybody has, in Bangladesh. So that is where the attachment is, and that is probably once I come, I will try to find the place, of their origin also. That is very important. So I think they were from Moymansingh also, Wow. So that is the thing. So that is probably the attachment that I have, with, let's say, with Bangladesh. And so as dermatologists, because I think we have a lot of exchange, because in the sense, even for our conferences, you people have been coming. In PigmentoryCon, for example, in Kolkata, I saw so many people coming. So you are very welcome to join, our association, the Pigmentary Disorder Society. Dr. Zeenat had mentioned once also that we can do another. We also have the Indian Women's, I'd like to tell all the dermatologists here, we have two very good, robust associations, which I have built up. I built it up for the people. One was the Pigmentary Disorder Society, which has both national and international dermatologists. and the Indian Women's Dermatologic Association, but it caters to people, like we have people from Philippines joining us. We also have people, you know, from other places, so you're very welcome to join. We have programs. You can come and present. You can have your own little session also there, you know, if you want to. Especially for pigmentary disorders, you definitely can, you know, because we also have the journal, Pigment International. Okay, so, you know, can you get a copy of the journal Pigment International? It's in the other room. So there's a, you know, Pigment International journal you might have heard of. Yeah. So please send articles to that. Log on to www.pigmentinternational.com. I repeat, www.pigmentinternational.com. You're very welcome to send your articles, share things. This is the journal. It is there online, but at the same time, if you want copies also, you can always order at Walter Kluver's. Walter Kluver's is the same publisher that does the Indian Journal of Dermatology, Venereology and Leprology. So you can always get subscriptions if you want for Bangladesh. People do ask, you know, from Nepal. So you're very welcome. You can send articles. If you want to take part in symposia, writing something, we are there to, you know, always help you. So please, my message is that we are always there, you know, and to help you out, because even I have been working in institutes and I have made my way, and you know, globally now, we are all recognized, you know, as Asians. It's very important to be recognized because we see so many diseases. So even to the West, we can, you know, give them so many good ideas to treat. So you're very welcome to reach out to us, join any of our associations if you like, collaborate with us, and let us have more of these, you know, interactive sessions. Not just online, we can also have after COVID, you know, let's hope that as soon as COVID is over, we can also have these mutual exchange programs, you know, across the borders. So that is there for the young dermatologist. My message is, please remember that cosmetic dermatology is very attractive, but what will stand you in great stead of time is your medical dermatology, isn't it? We are trained to be medical dermatologists with little bit of surgery. If you have a sound knowledge in medical dermatology, you will be the best dermatologist. So it should be 70% medical dermatology, 30% cosmetic dermatology. So I think that is very important. So, you know, if any of you want the information on the Indian Women's Derm Association, which is, you can be a sister organization of that, or if you want to even join the Women's Derm Society is also there. Or if you want to join the Pigmentary Disorder Society, we are there. The second thing is, I'm also the chairperson of the International Society of Dermatology Mentorship Program. I think 1 or 2 people from Bangladesh have already taken mentorship, you know, so you're most welcome. As soon as COVID is over, there will be applications again next year. So at least 2 people, you know, they will look at your CV and your work, and you can, the young dermatologists can go and, you know, do mentorships with people all over the world, whether it is in Europe, USA, Asia, India, anywhere. The teacher is important, I think, not the country, isn't it? So thank you so much.
Thank you, madam. We hope that we will overcome the pandemic of COVID-19, and we hope you will be here in Bangladesh in our next DAT conference.
Definitely, definitely.
The next year.
Yeah, I think there is a question by somebody how to join the Women's Dermatologic Society.
Yeah.
Log on to www.womensderm.org. I repeat, www.womensderm.org. And for the Indian one, which is easier for you to join, it's a one-time payment, www.indianwomensderm.com. So the women's derm is common between them. This is .com and that is .org. So you're very welcome, and you have the Pigmentary Disorder Society, again, .com. So you can go to any of these websites.
Thank you, madam. I now request Professor Dr. Mohammad Shahidullah Sikdar to close the session and a short speech for the participating dermatologist.
Thank you, Dr. Saiful. This is a wonderful experience today. Actually, we have gone through a very, very attractive and resourceful lecture being done by our guest speaker, Professor Reshmi Sarkar from India. Undoubtedly, she is the popular dermatologist not only in India, rather in Bangladesh, and I believe she is popular throughout the whole world. So we are
Thank
very
you,
much
sir.
lucky. Yeah, welcome. Actually, we are very much lucky that this pandemic probably created this opportunity to have this webinar today with this very researchful dermatologist from India. And as she already mentioned that she has some attraction especially for Bangladesh because of her origin, her parents having some sort of origin from Mymensingh, like this part of Bangladesh. And I believe, as she told, that she would visit Bangladesh in the earliest possible time after if we could overcome this COVID situation very soon. Now, we believe that our next conference of BAD, she would be highly honored to see in our conference as guest speaker from India. So
Thank you so much, sir.
in advance, I inviting her to come in Bangladesh in our next conference.
Thank you. Thank you so much, sir.
Welcome. Actually, we have seen this is really an art. As she told already, that there are some indications where we can apply chemical peels. And as she mentioned, hyperpigmentation would be the indication, and complications may be the hyperpigmentation. So what we are treating, we must need to see which patient and in which dose and in which agent would be suitable, and which procedure and what would be the measures to have, in true sense, the less side effect and to get. This is very important to select this patient, select the, these agents as well as the procedures, and by minimizing the side effects. This is very important, what she mentioned, what we have learned from her lecture. And I believe it is undoubtedly very popular lecture because our junior dermatologists especially, they were very much interested to know something for her, from her, in true sense, which are being very much prevailing. This demand is very much prevailing in our society, but in true sense, our young dermatologists are learning, they are practicing, but exactly the institution for practicing this cosmetic dermatology is not being yet developed very regularly in our country. So mostly our young dermatologists are in learning stage. So undoubtedly they are being much benefited by observing this lecture today. And I myself also can say that she is really an wonderful teacher, wonderful cosmetic dermatologist, wonderful dermatologist working in pigmentation. And already we have seen her access both in India and in other parts of the world, and her authorship in the research work as well as clinical practice. So I am very much grateful to her that she managed her time, and this is a quite big lecture, more than 1 hour, and she is very much patient to reply the questions, the asking, and the things which need to know by our dermatologist. She is kind enough and she replied very patiently, and we are very much grateful to her. And I last of all, I am telling her that we like to see her whenever our dermatologist like to know something from her by connecting about this linkage, or physically our dermatologist may go there, or you may visit when you get any
Sure.
opportunity to Bangladesh.
I'd like to, that's why thank Dr. Fatima Wahida also, because she's been in touch, and she kind of got us connected. So thank you, Hello, Fatima. She was writing, in between. And so many of your other students, Thank you.
Actually, like Fatima and Wahida and many other Asberi and many other young dermatologists, they are very much eager to know, learn these procedures from you. So I believe that you will make some time for them to teach them, and they ultimately not only the patients, rather our academic arena would be very much benefited by sharing this knowledge from you.
Right.
So
next time, Amra, we can keep cases also. Next time, case-based to korte para jete pare in the future.
Yes, this would be very good, because if we can demonstrate practical procedures by seeing some videos or like this live chemical peeling procedures, that it would be more beneficial, it will develop more confidence to our young dermatologists. So undoubtedly, we may arrange like this practical classes like these practical procedures. So it is undoubtedly very much beneficial for all sections of our dermatologists, senior dermatologists and junior dermatologists and mid-level dermatologists. And I am thanking you again from Bangladesh Academy of Dermatology that you are kind enough for making time for delivering such an wonderful, very researchful, quality lecture you have delivered today. We are grateful to you, and we hope to see you again and again among us. Thank you very much. Thank you all.
Thank you, sir.
Thank you,
One
Namaskar.
declaration. Okay, thank you.
Bala.
Yeah.
One declaration
You
for
can
us.
declare.
Our next webinar, the 17th BAD webinar, will be on 22nd of this month. Professor Dr. Marco Ardigo from Rome, Italy, will present a speech on confocal microscopy on general dermatology. We hope you all will participate here. And I want to give thanks to Dr. Fatima Wahida again, as he was the key person to connect me with Professor Rashmi Sharkar. Thank you again, Dr. Fatima Wahida, and Madam, we all are very grateful to you. You give time for us in this your busy schedule during the time of this your IIDBL election polling. Thank you again, and we pray for you for your.
In fact, some people from Bangladesh were writing that we are casting the vote for you. I was laughing at that actually. They've written affectionately. Yeah. Thank you.
Thank you, Madam.
Okay, thank you. Namaskar.
Okay.
Really nice.
Namaskar.
Everybody, we'll see you again. Thank you.
Yeah,
Goodbye.
Okay. Bye.
Bye.
আনিস, তোমাদেরকে ধন্যবাদ।
তোমাদেরকে
অনেক ধন্যবাদ ইউনিডারমা। থ্যাংক ইউ ভেরি মাচ। আসসালামু আলাইকুম। নমস্কার।